Atrial fibrillation is a very, very common arrhythmia. And to understand it, I'm going to first show you how things are supposed to work, and then we'll talk about how atrial fibrillation works. Everybody can hear me, right? I've been told I'm pretty loud, so usually I don't need these things. So the heart essentially is a hollow muscle with 4 chambers. It helps, those of you who know automobiles, it helps to think of it as an engine, as an automobile engine. And just like an automobile engine, it has a mechanical part and an electrical part. And they both need to work together, and they both work separately as well. The mechanical part is the hollow muscle. Essentially has 2 holding chambers up here, the right atrium and the left atrium, and the 2 strong pumping chambers in the bottom that are the ventricles, or pistons if you want to think about them like that. And they provide the force of the contraction. Now, the electrical system is specialized bundles of muscle, little fibers that run in a certain direction that conduct electricity faster. Electricity is what you see when you get an electrocardiogram. It's very small, it's on the range of millivolts, but it's electricity nevertheless. And it starts up here in the area of the right atrium, at the top of the right atrium, called the SA node, the sinoatrial node, which you can think of as the ignition. And the ignition fires 60 to 100 times a minute, sends a signal down to the distributor here called the AV node. And that distributor sends a spark cable to each one of the 2 pistons to make them beat in unison, okay? So one fire here, sends one here, and that's all's happy. And this, and this thing responds to adrenaline, to your state of mind, to awareness. So it goes faster when you're awake. It goes faster when you have a bear behind you. And it goes slower when you sleep, hopefully. So fires from there, sends a signal to there, sends a signal down here. And this is what the EKG ends up looking like. You have a little dome here called the P wave, which is the activation of this chamber up here, and then they have the big spike, which is the activation of the ventricles as this is happening. So what's atrial fibrillation? Well, atrial fibrillation, unfortunately, it's a free-for-all up here. This SA node that I told you about, it works when it needs to. So whenever this happens up here and everybody starts firing on their own, the SA node just sits idly by because it doesn't need to do anything. Everybody's going faster than it. So multiple areas generate that impulse, and they all are trying to get in through, at the same time, through the AV node. And those of you who remember your college days when you were having to sign on for classes, and there was a line, and there were 200 people here, and the desks were out there, and had to get through the same doorway. It's not a very orderly process when things like that happen, and people get in bursts. A number of people get in, and then they get clogged in at the doorway, and another and that's exactly what happens with atrial fibrillation. It's not very orderly. It's what we term irregularly irregular. And there's no P waves anymore. There's just this undulation here with all these guys firing at the same time. So it is the most common sustained arrhythmia. That's why so many people hear about it and so many people raise their hands. Average prevalence is 4% of the population, but increases with age. The important thing is that the risk of embolic stroke in general is 5% per year. Now, that doesn't sound like a lot, but it's kind of like you have a 20 little ticket lottery at your church. And you buy one of those tickets, and the prize is a stroke. And at the end of the year, you didn't win, but guess what? You get to buy a ticket for the next year. So the younger you are, the better your chances of winning or losing, depending on whether you want to look at it. So the risk of embolic stroke, even though it's only 1 of 20, if you live 20 years, is nearly 100% if you're in atrial fibrillation. See? So it is actually the most important thing there is in atrial fibrillation. Symptoms? Well, some people have none, absolutely none. And the problem with that is that they sometimes show up with a complication of it. Now, the people that have atrial fibrillation and feel it, feel palpitation, feel short of breath, feel dizzy, feel fatigued. It's not a fun thing to have when you feel it. Demographics by age explain what I was trying to tell you. The population is thinner at the higher age ranges, but look what happens with atrial fibrillation. It goes way up. It's said that approximately 20% of the population has atrial fibrillation around age 80, okay? So if you have 5 people, age 80 in a room, one of them has atrial fibrillation. And that will explain again why so many people raise their hands. There's 3 kinds of atrial fibrillation. That's mostly for us doctors to be able to talk about it and understand each other. Paroxysmal means it comes and it goes. Persistent means that it comes, but it doesn't go unless you make it. It can be cardioverted, and it usually stops with that or with drugs. Permanent means that it really doesn't want to go even when you try really hard. And sometimes we need to resort to higher things that we will talk about later to do that. It is what we term a continuum, meaning that you start here and you advance through here. So initially it's paroxysmal, and then with time it tends to advance to persistent and later to permanent if left alone, and sometimes even if you're trying to do something about it. This is just to show you that it ranks up there with, this is quality of life. Normal quality of life is up here in white. Having a heart attack doesn't really detract that much, you know, and most people after a heart attack get their life righted up and they feel better and do this and that, and so they stay up here in the quality of life. But people like, if you know somebody with congestive heart failure, they feel pretty crummy most of the time. Well, atrial fibrillation is not that far from congestive heart failure. Even though it's a relatively minor thing, people feel poorly. When they feel it, they feel very, very poorly. So it is important to understand that, you know, that they are not just telling you because they feel like it. They do feel and report to feel very poorly. The more atrial fibrillation you have, the better the chances of you remaining in atrial fibrillation. So if you just leave it alone, you'll have atrial fibrillation forever, probably. So these are people that have cardioversions done, and when their atrial fibrillation has been on for over 12 months, most of them are back in atrial fibrillation by 6 months. So about only 70% of them go back to atrial fibrillation if they have been in atrial fibrillation for over a year. Now the people that have been in atrial fibrillation for a short time remain in sinus rhythm. It's the opposite, remain in sinus rhythm about 70% of the time when they are in when they are checked after cardioversion. So the shorter the time you've been in atrial fibrillation, the better your chances of remaining in sinus rhythm after we do something about it. So it's useful to think about atrial fib as a separate set of problems because there are 2, and actually 3 very different aspects to it. The first and foremost and the most important is the risk of embolism. A clot forming by and going somewhere in the body. Why? Well, if you leave blood pooled in a certain place, it will tend to clot. You know, that's what blood does. So whenever the heart beats, that upper chamber, that ignition makes the heart beat a little bit, but enough to clear the surface. But when you're in atrial fibrillation, it's kind of trembling. It's wavering. It doesn't generate a forward output. So the blood is effectively pooling in that place, and a little clot tends to form. And the longer you've been in that fibrillation, the higher the chances of that clot forming. And then that clot, when it moves, it can go anywhere that the blood goes. Usually we find it more often in the brain because that's what gives the biggest symptoms, but it can go to the heart and give you a heart attack, or it can go anywhere in the body and give you a peripheral embolus. So that is the first thing we need to think about, and that's going to be the mainstay of treatment. Secondary symptoms. Symptoms are separate, and they can be treated with medicines to try to ameliorate them, but by and large, when you treat symptoms, you're not treating the clotting and vice versa. So the fact that you're feeling better doesn't mean that you're protected and vice versa. So it's really important to separate it. And the third one is something that you really can't see, is that the fact that many people develop cardiac dysfunction because just think of it again as an automobile engine. If you run it at 4,000 RPM all the time, eventually it's going to break down much sooner than it would if you ran it slower. So the heart also tends to wear down when it's being run faster than it should be. And that causes cardiac dysfunction. And sometimes people that don't feel it present in the heart failure with atrial fibrillation and rapid rhythm just because that is the first thing that it's going to give you an idea that there's something wrong. So that's why, not having symptoms with atrial fibrillation is sort of a mixed blessing. Sometimes it's not a good thing. Generally speaking, the rhythm itself is not very dangerous. It's not like ventricular tachycardia or ventricular fibrillation that will kill you on the spot, really. It will cause a cardiac arrest. Atrial fibrillation, you can hang around for years with it, and it's not going to by itself do something. And some of the good things about atrial fibrillation is that it sometimes is a sign of something else that is fixable, and when you fix that, you fix the atrial fibrillation. Like thyroid disease. Some people present with hyperthyroidism, Graves' disease, with atrial fibrillation. You fix the Graves' disease, atrial fibrillation goes away, you live happily ever after. Some inflammatory diseases like lupus, like rheumatoid arthritis, can present as atrial fibrillation as well due to irritation of the layers of the heart. Some valve diseases, some leakages of the valves of the heart can present like that. Some infectious diseases can affect the heart and give you atrial fibrillation, including viruses. Those can sometimes cause the heart to get weak as well. Those are usually less easy to treat, but the good thing is that if they resolve with time, then the atrial fibrillation has a chance of going away. Sometimes you get somebody in an emergency room with a pulmonary embolus. Somebody who's never had atrial fibrillation shows in the ER after having a trip from Hawaii, and they're in atrial fib. And the first thing we think about, of course, is atrial fib, and it's a pulmonary embolus, and lo and behold, many times that's what we find when we do the scans for that. And the last one, which is very, very common, is coronary disease. Sometimes people show up with heart attack or with ischemia, and their symptom is atrial fibrillation, not chest pain. And the last good thing about atrial fibrillation is that it often resolves spontaneously. It goes away on its own, and sometimes, you're good for several years if you have had only one episode. That's the good. Well, the bad about atrial fibrillation is what I've been harping about. If asymptomatic, some people first present with a stroke, and they never knew they had atrial fibrillation. There are some arrhythmias in which it can really be lethal because it can present then as ventricular fibrillation. Usually it's in young people that have Wolff-Parkinson-White, and it can transmit, all 300 beats a minute at the same time without having to go through that little doorway that I told you about. If they have a bad connection and they have something called Wolff-Parkinson-White, then atrial fib is a different thing for them. Other bad things about atrial fib, it can engender tachycardia-induced cardiomyopathy. Big word to say that the heart gets weak when it gets run really fast. And then you fix the atrial fib, and typically the cardiomyopathy gets better. If you just look at all comers, atrial fibrillation increases mortality by 1.5 times. So it's not to be trifled with. And the ugly parts of atrial fibrillation are that it is the most difficult treatment thing to treat. And I'm from Florida, so I like to liken it to cockroaches. It's kind of like you can do anything you want, and they will be there. Even if you don't see them. But if you try to kill them all, remember the cockroaches are far more resistant than we are. So we end up killing people instead of killing the disease if we try too hard. So you have to be careful when you try to treat people with it. The treatment modalities can be highly controversial. And doctors love to fight about atrial fibrillation, and we've been doing that for years and years. We've had new oral anticoagulants now come out, which are sort of a blessing for some people. Some antiarrhythmic agents have been used, medicines to try to control atrial fib, but then we find out that some of them are actually more harmful than good, so we got to be careful with that too. And then ablation has come on its own over the last 10 years or so and has become a blessing again, but it's only for the right people. Not everybody will be helped by ablation, and it's important to understand who. And it also accounts in the bean counter side for very, very high costs because atrial fibrillation causes a lot of visits to the emergency room and a lot of people staying in the hospital because they feel really ill with it. What do we do about atrial fib? So the most important thing is to slow down the guy, and we do that with calcium blockers like diltiazem or verapamil and beta blockers like metoprolol. Or carvedilol, anything that ends with an ol is usually a beta blocker. There used to be a third line here, digoxin. Digoxin is used less and less each day because digoxin we've been used since the past century when it was called foxglove leaves and you used to chew it. and it was used for dropsy, which was the name for congestive heart failure then. Over the course of, over a century, we found out that digoxin is not the best for some things, and in atrial fibrillation, it may actually increase mortality in some cases. So we have been shying away from using it. So it's less and less common that we use digoxin for atrial fib. Now, again, the most important thing, anticoagulation. Warfarin has been used for many, many decades. And warfarin is a medicine that people love to hate. But I need to tell you that it has saved more lives than many other medicines that are available. And once everybody who has a heart valve, an artificial heart valve, his life has been saved by warfarin. People that are taking warfarin and suddenly develop a little bit of blood in the stool, and then they find out that they had a polyp and it was caught in time because they were an anticoagulant. If not, it would have grown much larger. So there are a number of silver linings. And warfarin is very good when people are disciplined and they know how to eat and when to take it, and they are followed closely by a clinic. It actually can become second nature. And some people just develop a discipline on how to use it, and it doesn't need to be feared. Atrial fibrillation is only treated with other things when it's non-valvular. So if atrial fibrillation is due to a valve problem, warfarin is the only thing that we can use these days. Or if you have a valve, warfarin is the only thing that we can use these days. Now, these new guys have come out called the direct oral anticoagulant, or DOACs. We love acronyms in medicine. First one was Pradaxa, then came Xarelto and Eliquis, and there's a couple more lately that have come out. Of these, the important thing is Xarelto has the benefit that can be taken once a day, so it's easy to take and harder to forget. Eliquis has to be taken twice a day, and a lot of people take it once a day, but it doesn't really protect when you do. So you really have to take it twice a day. Eliquis has the benefit that it's not cleared by the kidney, so people that are in kidney failure can take it, whereas Xarelto gets accumulated and cannot be taken with people with kidney failure. So give and take, different things for each one. Aspirin, there was a time in which we thought aspirin was half as good as warfarin. And that is mostly a thing of the past. We found out that it is just not nearly good enough unless you have a heart that's totally, totally normal and you're younger than 65 years of age, in which we term you lone atrial fibrillation, and aspirin alone is okay. But aspirin, when it's been looked at coldly in a trial, has absolutely no effect after age 65 for atrial fibrillation. So if you're taking aspirin for atrial fibrillation after age 65, it's wishful thinking. Plavix and other antiplatelet agents are also used sometimes to treat atrial fibrillation. There's absolutely no evidence that they help avoid embolisms. They are termed, blood thinners, but they do not work the same way. So either Plavix or aspirin, if you're over age 65, they have no place in the treatment of atrial fibrillation. That's not to mean that, you had a stent and you need Plavix. The Plavix is for the stent, but it's not for the atrial fibrillation. And antiarrhythmic drugs. Sometimes, usually that's when you guys get to meet us, and because somebody wants to put you on a medicine to try to control it. And since they've had a little bit of a checkered history, they want us to be the ones to recommend them. They were originally used very indiscriminately in the 70s and 80s until they found out, they did a big, big trial. And many times in medicine, we do trials with things that we know what the result is going to be. And this is a trial that was done knowing that it was going to turn out that, it was good for you. And lo and behold, they found out that people were dying in excess when they were taking these medications as opposed to taking sugar pills. So we took a step back and started to see who was the one that was being affected. Initially, the medicine was quinidine, but there was another one called enconide, and there was one called flecainide that was also used in different trials, and all those were noted to have a higher mortality rate. And we finally figured out that it's anybody that had coronary disease or structural heart disease, in essence, a weak heart. So what happens? Weak hearts are the ones that usually have arrhythmia, so those were the ones that were being used wholesale with these medications, and that's why we saw those effects. So nowadays, anytime that we want to start this medication, we go by and we look at your history really carefully and make sure that you don't have anything that would contraindicate, that would negate the use of these. And these are the three that we're using mostly. Sotalol, which is a beta blocker, but also an antiarrhythmic. Flecainide, also called Tambocor, and amiodarone. Amiodarone is a time-honored drug that is probably the most effective antiarrhythmic known to man. It can be taken once a day. It has a lot of good things, but it has very, very powerful side effects, and it really is the subject for a separate talk. But amiodarone has to be taken with great care. If it's going to be taken, it has to be monitored very carefully. And again, and I'll tell this till they take me out in the white jacket, you know, most relevant factor in atrial fibrillation is anticoagulation, and without that, you're not really treating atrial fibrillation, particularly if you have a risk of anticoagulation that's elevated. You're not doing anything if you're not treating the risk of clotting with anticoagulation. So now we've come out with a nifty little way of saying who is at risk, and it's called the CHADS-VASc score. It consists of 9 points, and with 1 point, you can take aspirin, and anything above 1 point, you need an anticoagulant, and the only thing that more points mean is that your risk is even higher. And unfortunately, the first point is awarded at age 65. You get a second point at age 75. If you have high blood pressure, you get another point. If you have diabetes, you get another point. If you've ever had a stroke, you get 2 points right off the bat. Vascular disease and blockages anywhere, coronary, peripheral, another point. Sorry, ladies, but female sex accounts for a point right at the get-go, and you know, even when you're younger. So it follows that any girl after age 65 has 2 points and needs anticoagulation if there has atrial fibrillation, and it's totally legal discrimination. I'm sorry, but it's just the way it is. Women have smaller blood vessels, have smaller chambers, and that tends to, in some way, the hormones tend to produce a milieu that's more likely to produce clots, and we think that that has something to do with it. Women have higher rates of pulmonary emboli, for instance. So it has something to do with the hormones that otherwise protect you and other things. There's always a give and take with that. So we always calculate what the CHADS-VASc risk is of a person that comes to see us, and anytime you have more than 1 point, unfortunately, you need an anticoagulant. So other things we do are trying to modify atrial fib so that you won't have it. And we noticed at some point that the left atrium, which is where atrial fibrillation seems to come from, is different than the right atrium. The left atrium has these 4 veins coming from the lungs that carry oxygenated blood into it that create these 4 holes into this otherwise smooth surface. So the electricity that I've been talking about in the heart, it is a little bit different. It's more like actually like the waves that you produce in a lake when you drop a stone. You know, it spreads in every direction unless it's carried by one of these wires. Otherwise, it spreads in every single direction. But the same as in a lake, if you find a log in the way or if there's an island, then it kind of breaks down and becomes turbulent around it, and it doesn't keep progressing. Well, there's 4 of those islands here in the left atrium. And early on, we figured out that this had something to do with why atrial fibrillation was happening there. So in came what's called a primary AF ablation, or radiofrequency ablation, or pulmonary vein isolation, which has become the most effective form of therapy now. Again, unfortunately, it works best in people that are younger, aged less than 70. The reason why is atrial fibrillation starts happening more as there's more fibrosis in the heart, and it's a process like arthritis. I mean, it's a degenerative process that happens. As you age, you get more fibrosis, and it works less well as there's more fibrosis happening in the heart. So we try to keep it in reserve for people that are younger, with some exceptions. Sometimes we do use it in people older than 70, but by and large, that's what we try to do. Again, because the more atrial fibrillation, the more chances are you are going to remain in atrial fibrillation. So people that have had atrial fibrillation for a very long time are poorer candidates than people that just started having atrial fibrillation. And again, that's thought to be because of fibrosis. The longer you're in atrial fibrillation, kind of like when you don't use a joint, you know, it becomes fixed in that position that you don't use it. It becomes fibrotic. Well, the heart also, when it's not used to pump in that chamber, it starts becoming fibrotic, and it starts becoming much harder for it to be in normal rhythm again. Success rate for the atrial fibrillation ablation is approximately 70%, not 100, not 50-50 either, although some are, but it's sufficiently high to use it. But sometimes you need a second session if the first session was not quite as good, and it has a recurrence rate, meaning that you fix it, but a few months later it starts coming back, and recurrence rate is about 10 to 20%. So sometimes it's not a complete fix. Now, people that do it and get successfully ablated and get over the first year or so without having recurrences, they do very well. Yes? What is ablation? Oh, I'm sorry, and I was assuming. Ablation is burning. And I'm about to show you what it is a little bit later, but I sort of assumed that everybody knew what ablation is. Ablation is putting a catheter inside the heart and burning a little line, which causes fibrosis, which I've been talking about. Fibrosis does not conduct electricity, so it creates an insulation. Wherever you touch that and burn it, it doesn't conduct electricity anymore. So it fixes the problem of electricity trying to go everywhere. But I'll show you a little bit more in a moment. The other thing is that ablations, sound that, oh, that's the thing to do, but they have a small or significant complication rate. When you're burning inside the heart, you can burn through. It doesn't happen very often, but if it happens, it's a big disaster, and sometimes you have to go to the operating room and have that hole oversewn. So if I say 1 to 2%, that doesn't sound like a lot, but if you're that 1%, it's 100% for you. So it's something that we have to think anytime we offer you any of these procedures. And the last thing is some people come to us and say, oh, I want an ablation so I can stop Coumadin. Well, it just doesn't work that way. Remember what I told you at the beginning, that they're separate things? Ablation functions for symptoms, but it does not change the fact that you're 65 and have diabetes and have hypertension, so your risk of thromboembolism stays the same. So after ablation, you still need anticoagulation. So what is ablation? Well, we put catheters inside the heart. Anybody who's had an IV in their veins has had a catheter, a very short one, albeit. But these catheters are much longer, and we put them through the groin, where you have a vein as big around as your finger, and we can put 3 or 4 catheters through there, through both veins in the groin, and we use them to put them in different parts of the heart. And trust me, there's a heart here. You just see the shadow of it. And this goes, we put a catheter to the ventricle, to the main pumping chamber, one here in the middle, where the distributor that I told you was about, and one to the upper chamber, and then we put catheters through a little hole here that it's either there, it's called a PFO, a patent foramen ovale, or we make it with a little needle. We actually punch a little hole to get to the left side because there's a wall of tissue there that doesn't let us through. And then we put catheters inside those veins, those little holes that I showed you, and we try to see whether those rhythms are coming from in there. Those are the pulmonary veins. So we see things like this. You see there's one beat here in the ventricle, but there's many, many beats here in these other channels. So there's like 4 or 5 beats for each beat in the main pumping chamber. So that's where it's firing from. And in this case, it seems to be coming from the left upper pulmonary vein. And we put in another catheter that is actually a sonogram catheter, and we can see the inside of the vein, so we can see where we're burning to try to avoid places that are dangerous. And then we can use the information in those catheters to create sort of a GPS map of your heart. We have a grid under you, and the catheter has a transmitter. And that catheter, as we move it around, it sends a signal to where it's at, just like GPS, to the map underneath. And as you move the catheter around, it creates a larger and larger map, and sort of a place where you're at. And then we can use that map to mark where we've been and mark where we've burned, so we can connect the dots and kind of stop the atrial fibrillation. So the object of the game is to isolate these places that are firing. And so in Montana terms, you have herd of rowdy cattle, and you fence them in so that they won't mess up your grounds, and you're golden after that. So we create 2 fences around here, and sometimes we connect them over the top here, and sometimes we connect them down here as well. And that usually, again, 70% of the time, keeps them under control. The problem, just like with cattle, is that they're very good sometimes at finding breaks in the fence. And once one gets through that break, the others follow through, and you get a recurrence. So sometimes these are not lines. These are made out of dots. We burn, and we burn again, and we burn again. That's why we need a map to sort of connect the dots and create a continuous line. So between any of those dots, there could be a recurrence sometimes. And so we try to burn sufficiently to connect the dots, but not enough to perforate to the other side. It's fancy footwork. But it works most of the time. And the end result is this. You're in atrial fibrillation, and suddenly, boom, it cannot get out anymore from those places, and you're back in normal rhythm. Instead of having all these extra beats, now you're back to organized rhythm. There are cousins to atrial fibrillation. There's one called atrial flutter, which is a little bit better behaved. And atrial flutter courses in a... Atrial flutter actually comes on the right side. It's not like this, and it's better behaved because it has to traverse a longer circle, and it goes in a counterclockwise fashion around the right atrium. And it looks like this. It looks like a sawtooth in the electrocardiogram. And that one is easy because there's one little place in the right atrium that it has to go through. It's called a bridge of tissue between a hole made by the tricuspid valve and a hole made by the inferior vena cava. So there's that little bridge of tissue there. And if you make a fence just there, then the cattle can't go through anymore, and you're fixed. And so this has been done for actually a lot longer than atrial fibrillation, and has a higher success rate. Success rate is about 90%. So if you have atrial flutter, the problem may not be quite as severe, and it's easier to fix. Atrial flutter also needs anticoagulation, and if you have risk factors for that, this does not fix your need for anticoagulation. So unless your doctor tells you you don't need anticoagulation anymore, you still do. And this is the dots that I was telling you about. This is a line through the flutter bridge. This is in blue, that's the bridge, and then we just put points and points and points. And I make it sound real simple with the heart being not a straight line and this and that. The thing is beating the whole time, and valves are moving, and we cannot ask him to stop just for us. So when you put a point here, the next one ends up a little bit to the side, and the next one over here, and there's ridges that go up and down. So you need to just keep, making it darker and darker until it suddenly stops, and then you know you're done. And then you need to probe from each side, trying to see whether there's any breaks, and then you're done. That's why these things sometimes can take, 4 to 6 hours to do with you sleeping the whole time, but we're hard at work there. And so those are the two ablations that are directed to the rhythm that's happening. Now, there's a third way of doing this, and it's sort of the nuclear option, if you will. And when there's all this happening up here and we cannot control it, then remember I told you that there was a distributor, and the only way to the pumping chamber was through that distributor. Well, we can blow the distributor out. And then the heart beats on its own at about 20 to 30 beats a minute, and it's regular again. The problem is 20 to 30 beats a minute is not enough to live comfortably, so you would need something else, and then you put in a pacemaker to drive it a little faster. So that's called an ablation of the AV junction or AV node, and that always requires a pacemaker. It is a very good way of doing it. It has very good symptom relief and quality of life numbers. About 90 to 95% of people say that they feel better. It does require a pacemaker for the rest of your life. The pacemaker can be programmed. It's a good thing. Yes?
So what if you start with the pacemaker and then have the AFib?
Then you have both options. But you still, it depends on which one makes sense. Oh, repeat the question. Yeah. What if you have a pacemaker before and then you develop atrial fibrillation? So you have all the options still open, because the fact that you have a pacemaker doesn't necessarily mean that you are restricted to this kind of maneuver. If it still makes sense for you to have a primary AF ablation and burn the vein around the veins, you will still have that with a pacemaker. But if you don't, and this is the real solution for you, then you just need a little burn in the AV node and you're done. So it's a 30-minute procedure typically. So it makes things easier sometimes. The disadvantages are that you need a pacemaker for the rest of your life. It's, again, anticoagulation is still required. So AFib, you can file it away and forget it, but it's still there, and it still can hurt you if you don't take blood thinner. It's costly. These little pacemakers that look so pretty are about $8,000 a pop, and that's no labor included. Such are the things that drive costs up in this nice country of ours. Again, a subject for another talk. The good thing is that the quality of life improves, and there's significant reduction in all the symptoms. And that's, again, proven by a number of studies. This is what a pacemaker looks like. Most people wear it if they're right-handed. They wear it on the left shoulder, under the skin, a little lump. So if you're dressed like you today, everybody here could have a pacemaker. Nobody would know about it. It's just very, very small. Was that me? Okay. The only problem with this, and this I need to make it, so why don't we do it in everybody? Well, because I told you there's 90 to 95%, so that means that 5 to 10% of people don't feel better with it. And if you do, then you've taken an irreversible step. You cannot get you back together again. This is something that once it's done, it's forever. And you can try to make things with the pacemaker. You can try to make the pacemaker a better machine by putting in a second lead, but it's something that to be contended with. With the other one, you still have all your options open. This one is a definitive thing, so it's always important to understand that. There have been other maneuvers used for atrial fibrillation, and we even, for some time ago, we were using atrial defibrillators. There were people that hated atrial fibrillation so much they were willing to shock themselves. And what they hated most was having to go to the hospital each time they needed a shock to convert it. So they say, well, don't you give me one, and I'll take it home, and I'll do it in the safety and comfort of my own home. So there were defibrillators, and there's still some available that can deliver a shock if you, to yourself. And they take their favorite brandy and their favorite easy chair, sit down, and push the button. And, but it is really a very, very rare patient that can do this repeatedly. And it's really fallen into disuse, especially since ablation has become so much better. Initially, ablation was less than 50-50 effective, and now it really has become much, much better. And some people hated it even enough to have their chest cracked open for it. And there is surgery for atrial fibrillation. Sometimes people having bypass surgery have what's called a MACE as part of the procedure, and that's okay because you're already having your chest cracked open, so it doesn't really matter. But there were some people that had it just for the atrial fibrillation. I actually know a surgeon that did that because he couldn't operate, and there was nothing else available. And a guy named James Cox up in Barnes Hospital in St. Louis devised this operation called the MACE procedure. And the problem with this procedure is that it worked really, really well in Jimmy Cox's hands, but most other places that try to reproduce it never approached the good results that he had. So it is also used less often. It's used now more as a addition to bypass surgery, because a lot of people with bypass surgery get atrial fibrillation after bypass surgery. But it's not been used independently that much anymore. So, lots of different things. And there may be even more in the future. It may be things get better, and as technology gets easier and things get smaller, complication rates go down and success rates go up. So the important thing is to keep in mind that what it can do and what it cannot do. And the most important thing that I want to leave you with is that, when we not like to do something, is that the first 10 of the medicines first do no harm. And it is really important to know the limitations of what we do to avoid harm in things that are otherwise very beneficial.